morning, everybody. I bring greetings from India. I would like to thank Professor Ella Shab and the organizers for this opportunity. My topic is tunnel convergence issues in multi-ligament knee injuries and how to avoid them. So, if you look at the definition of multi-ligament knee injuries, injury to at least two of the four principal knee ligament structures, the ACL, PCL, posteromedial corner and the posterolateral corner. And the definition of tunnel convergence, the drilled bone tunnels for different grafts, ACL, PCL, ACL and MCL and LCL are placed too close to each other, and these tunnels either merge, overlap or intersect, compromising the integrity of one or both tunnels. The consequences of tunnel convergence are weakening of bone stock, graft impingement, loss of fixation, difficulty in future revisions, and suboptimal biomechanics and instability. And the principles of avoiding tunnel convergence, we'll come to some of these principles as we go along. And these are the attachment sites for the ligaments to the femur and the tibia. As you can see, there are multiple ligaments involved, and reconstruction involves grafting and fixing the graft with appropriate techniques. So what are the techniques that are optimal to consider in these situations? We cannot possibly give all options here. So on the medial side, there are 4 possible femoral and tibial attachments required for the ligaments, and in the lateral side, 3 femoral and 1 tibial are required. So you can see the potential problems here. Now, if you add the number of the tunnels required for meniscal root repairs and anterolateral ligament, the possible combinations are numerous. We will just go through the common scenarios and available tips to avoid confluence of these tunnels. Let's consider the common convergence of tunnels. First is the posterolateral posterior oblique ligament tunnel in ACL and PCL plus MCL injuries. Aiming towards the Jerdie's tubercle, which is normal practice with posterior oblique ligament reconstruction, will hit the PCL tunnel, but there's no threat to the ACL tunnel in this case. PCL tunnel is also at risk in superficial MCL reconstruction because it is placed much lower than ACL and goes posterior. So here aim the tunnel of superficial MCL anterior to fibula and more distally. And this shows the cross-section of how to avoid the PCL tunnel when you are placing the posterior oblique tunnel. Tunnelless techniques have been very handy, especially where multiple tunnels are required, and this is one recently published technique from India for MCL reconstruction. They use an anchor. And this image shows location of meniscal root tunnels in relation to ACL tunnel on the tibia. Some surgeons include the lateral meniscus posterior root tunnel with ACL tunnel, but that is not anatomical. We'll come to those later. So tunnel convergence on the femur can occur with fibular collateral ligament and popliteal tunnels. You can see that in both femur and tibia, where the tunnel is posterior, exiting posterior, that is ACL in the femur and PCL in the tibia, the chances of hitting the other tunnels are increased because those tunnels are traveling from anterior to posterior and across the diameter of the bone. With the ALL tunnel, tunnel collision was avoided by aiming the ALL tunnel 40 degrees anterior and perpendicular to the anatomical axis of the femur. A more horizontal orientation of the ACL with the anteromedial portal technique is a risk factor for tunnel conflicts. These are the different techniques to avoid tunnel convergence. We will go through them one by one. First is to leave the drill in situ of one tunnel. So if you leave the drill bit in one tunnel and do the other tunnel, when you hit the other tunnel, you will know you are hitting the tunnel. The other one is to avoid making the tunnel altogether. If you can use an anchor fixation, It is a better technique, especially in 3 ligament, 4 ligament reconstructions. And next up is multiple suspensory fixations. I'm increasingly inclined to using these options just because it gives us a lot of flexibility with the direction of the tunnel, and fixation strength relies on the strength of the opposite cortex rather than the cancellous and cortical engagement of the interference screw. And there are advantages and disadvantages of multiple suspensory techniques, but they may be employed wisely where necessary. In suspensory fixation, graft is suspended. Sorry, this is moving fast. So in suspensory fixation, graft is suspended against the far cortex, while interference screw compression, it compresses the graft against the tunnel. Suspensory fixation has better bone graft integration, minimizes tunnel widening, and it requires secure fixation, and loosening of the graft and bungee cord effect are present with the suspensory fixation. Tunnel widening is more common with interference screws, and similar, the outcomes are similar with both the techniques. They have a predefined trajectory and wider tunnel, and that is, they have no flexibility of changing the tunnel direction or diameter. So this is one ACL plus superficial MCL plus posterior oblique ligament. You can see just 2 buttons, one for ACL and the other for MCL on the femoral side. There are multiple options available here, and they may be done minimally invasive too, identifying the spots using a C-arm and placing them. You can see the pictures from the medial and the lateral side for 3 ligament reconstructions. I use suspensory for ACL also, so you don't see the fixation implant for the ACL in the radiographs. This is another example. And one more, this is LCL and PLC without other ligament injuries. This is ACL and ALL. I have used an anchor for the ALL, and you can see that proximity of the ALL anchor to the ACL femoral tunnel. This one is PCL, LCL, and PLC. The lateral reconstruction was done using a modified Larsen technique. The next step is to adjust the tunnel direction and depth differently in the staggering technique. You can see the effect in this slide. This shows posterior root tunnel for the lateral meniscus and the ACL tibial tunnel. Another option is to use staged reconstructions. When we stage, the first set of ligaments would have healed and would not compromise the fixation even if the tunnel converges later. One more option, use same tunnel for 2 ligaments. For example, lateral meniscus posterior root reconstruction and ACL. But the fixation here for the root becomes non-anatomical here. Next up is the pedicle grafts. Here one fixation is the natural attachment of the ligament, so there is no tunnel for that fixation, and this shows the ACL and ALL reconstruction. So if this track causes convergence, the options are to change the angle, to change the diameter by using a suspensory ligament, and change the depth by using a socket rather than a full tunnel, reduce still by using an anchor, and avoid tunnel altogether by using a pedicle graft. So to summarize, tunnel convergence is a major issue during multi-ligament knee injuries. Anticipate convergence issues and plan and avoid convergence using different options. Thank you very much.
Thank you, sir, for this very nice presentation. Now we have Dr. Hussam Said. He's going to talk to us about POL advancement in ACL injury associated with PLC laxity.
Assalamu alaikum. Post-medial corner advancement in high-risk ACL injury. Actually, how we treat our ACL patient is conservative management is still efficient. Yes, in patient without associated corner injury, as the capsular ligamentous and the meniscocapsular complex maintains the stability of the knee, so we can manage ACL patient completely conservative with good functional outcome. However, ACL reconstruction not achieve the objective in all patients with re-rupture rate about 30% and re-rupture due to other cause than graft rupture or failure than graft about 30 cases, residual laxity in 50%. Only less than 50% of ACL reconstruction can return to their same level of sport even in expert centers. Why this high failure rate? Due to presence of certain risk which interact together to decrease the success of our ACL reconstruction. We can classify our risk into external risk factor as malposition of the tunnel, new trauma, infection, or presence of meniscal injury. All of external risk factors are treated according to the cause chronologically. But in some patients, there is internal risk factor, internal risk in this knee or in this type of patient which make their ACL fail. These risks include knee laxity, either traumatic laxity. I mean by laxity not posterolateral or posteromedial corner injury. I mean internal knee laxity, or generalized laxity, or increased knee hyperextension, increased tibial slope, excessive external rotation, also female sex, and associated posterior capsular injury. How we treat internal laxity, as our prof discussed, by lateral extra-articular tenodesis. Lateral extra-articular tenodesis, including the anterolateral ligament repair and the old Lemire-McIntosh and modification and Ellison technique. What we need to find here? We need for another surgery completely from the lateral side and need graft and synthetic synthetic material to fix this graft. What about the medial side? Why all extra-articular tenodesis done from the lateral side? Any answer? Why all extra-articular tenodesis done from the lateral side? Because we, because we believe, like we study all that external rotation increase, so we want to stop external rotation, which is responsible from the lateral side. As when we do the dial test for the patient, yes, post-dial test, this patient have posterolateral corner injury. No, dial test is present in patient has posterolateral corner and the posteromedial corner. Imagine you injure your posteromedial corner, external rotation will increase. But we كما وجدنا يعني زي ما قالوا لنا تعلمنا. Please concentrate in these issues. Increase external rotation. Why external rotation increase? Either due to anterior subluxation of the medial tibial plateau or posterior subluxation of the lateral tibial plateau. So medial is responsible also about the lateral. In posteromedial corner injury, the anteromedial aspect of the tibia sublux anteriorly, and the reverse in posterolateral corner injury. The magnitude of external rotation reported after injury to the medial capsule structure is similar to that reported after lateral capsular structure. Also, rupture of the medial capsular ligament is the basic lesion for external rotation, not rupture of the lateral as we believe. So, Slocum and Larson warranted against false positive posterolateral corner examination or false positive dial test, and we assume that all positive dial tests are due to posterolateral corner, so we need for something lateral to do. The posteromedial corner, what's happened during ACL rupture? Excessive anterior translation, violent contraction of the semimembranosus tendon. This lead to overloading on the posteromedial structure and resulting in posteromedial instability. So the posteromedial corner is important second stabilizer to pure anterior tibial translation, and many patients with ACL can continue to have their athletic function due to intact posteromedial corner. Also in posteromedial corner injury, anteromedial rotatory instability, in the past we assume that all external rotation is due to posterolateral corner injury, which actually is due to the medial structure as evident by Robinson. What is the posteromedial corner? Is a neglected corner in the knee, lies between the posterior margin of the longitudinal fiber of superficial MCL and the medial border of the BCL, with 5 major components: the semimembranosus tendon, the oblique popliteal ligament, the posterior oblique ligament, the posteromedial capsule, and the posterior horn of the medial meniscus. Moeller states that as long as the semimembranosus corner, he called it the semimembranosus corner because the main dynamic stabilizer is the semimembranosus tendon. As long as this corner work efficiently, the ACL can be, this knee can be functional even in presence of ACL tear. Another component of the posterolateral corner is the BOL or posterior oblique ligament, which originates from the adductor tubercle and has 3 arms: the tibial arm, the capsular arm, and superficial arm attached to the semimembranosus. Also, the oblique popliteal ligament, which arises from the posterior capsule and defend out laterally and medially. So, the oblique popliteal ligament is considered part of the posterolateral corner and also part of the posteromedial corner. Here's again. The posterior knee capsule vary greatly in patient. It may be very thick or it may be with membrane, and this is another cause why some patient has internal knee laxity than other patient. What is the mechanism through which the posterolateral corner work? It's mainly break stop foramen, break stop to the knee joint. It prevents falling of the tibia anteriorly and the distal femoral condyle posteriorly in patients with ACL injury. What's the mean of knee laxity? Knee laxity, that patient during examination will find him that have Lachman anterior drawer test greater than 10 millimeter or grade 3 positive test. Increase knee laxity, increase risk of revision of ACL or failure and the bad reported outcome at 2 years postoperative. How the posteromedial corner assume his function, thermodynamic and static function of the semimembranosus tendon and the posterior horn of the medial meniscus. The posterior horn of the medial meniscus fixed by the musculotubular ligament, the contour of the posteromedial superior medial edge of the meniscus engage the medial femoral condyle during weight bearing, and the tension of the semimembranosus and the posterior oblique ligament and the oblique popliteal ligament, which prevents the knee from rolling back. And when the knee is completely extended, the tibia rotates externally to achieve screw position, tightening the posteromedial corner around the pouch of the medial femoral condyle. Some patients have external rotation excess than the other side in the injured knee. The ACL injury, the ACL actually limit both external and internal rotation. And you must remember that ACL injury is a matter of external rotation valgus in non-contact injury. External rotation valgus and hyperextension. What is the role of posteromedial corner in external rotation? In the superficial MCL, هي البرايمري restraint to external rotation. The BOL والposteromedial corner is important secondary restraint after the superficial MCL. What is the effect of tibial slope? Increase force graft, which lead to graft failure and may lead to increased posterior horn medial meniscus. We know that tibial slope effect managed by slope reducing osteotomy, but it is complicated surgery with high complication. Silman told that extra-articular tenodesis still work even in high-risk patient due to high tibial slope. We can do only tenodesis effect without need for slope reducing osteotomy in the first operation. Another shape of internal laxity is the geniorecurvatum. Geniorecurvatum or back kneeling or hyperextension. Even physiological geniorecurvatum must be addressed during ACL reconstruction, even physiological. Because it's 1/3 of patients with revision in ACL have genuine recurvatum. What is the function of ACL in genuine recurvatum? It prevents anterior tibial translation, internal tibial torsion, and knee hyperextension. The mechanism of injury is hyperextension. Frank Noya demonstrated that the posteromedial capsule is the main restraint against hyperextension. The OBL, oblique gluteal ligament, is the primary restraint to knee hyperextension and is important to prevent genuine recurvatum, and the BOL provides restraint against valgus stress, anterior and posterior tibial translation, and the internal tibial torsion. حاضر. يا دكتور محمد, what is the indication for posteromedial corner advancement? It is the same indication for extra-articular tenodesis. Posteromedial corner advancement is a procedure adjunctive to primary ACL, open procedure, about 20 minutes, medial knee approach, 5 centimeter approach, posterior to the medial epicondyle and extending distally to the posteromedial border of the medial tibial condyle. The posteromedial corner and the BOL is isolated with inverted L shape and dissected and immobilized. Matrix suture are passed through the flap and reinserted and fixed anterior and distally to the knee. Again, this is the posteromedial corner. This is the shape of our incision, L-shaped incision. The posteromedial corner is advanced anteriorly. The resulting flap are tight. Advantage of posteromedial corner advancement هو هنا المين advancement for me. أنا دلوقتي بعمل عيان ACL خلاص, وحصل عندي عنده excessive external rotation ومش عايز اضيف ميتال ثانيه ومش عايز اضيف اوبريشن ثانيه وما فيش مثلا وقت او ما فيش كذا وما فيش كذا, فانا ممكن استغل ان انا فاتح كده الانسيجن بتاع الجرافت هارفستنج, extended it posteriorly, dissected posteromedial, safe corner, ما فيش نيوروفاسكال باندل هنا, ما فيش اي ستراكشرز خالص, يا دوب هوصل للبي او ال او البوستيرو اوبليك ليجامنت واحملها ديستكشن واخدها كده زي دبل زي الشولدر ما بنعمل في البط بلا زمان, وباخدها وادفانس ات انتيرولي اند ديستالي وفيكس ات بوستيرو تيبيا. بخلي الاسيستنت يمسك الرجل في ماكسيمم انترنال روتيشن, انا وبعمل البروسيدر ده وفليكشن, يبقى كده انا اخر البروسيدر هلاقي الاكسترنال روتيشن قل ولاقي الهايبر اكستنشن قل. ده ببساطه يعني زي بالظبط الدبل بريست او البط بلاي بروسيدر. وانه technically easier, no hardware, no metal, no secondary operation, no tunnel convergence or no tunnels at all. Posteromedial corner is a promising option in treatment of internal knee laxity associated with ACL tear. A technique focused on the biomechanically demonstrated main restrictor to the knee laxity. The posteromedial corner also is less complex anatomically. It is no less important functionally than the posterolateral corner. Thank you.
Thank you for this very nice presentation. Dr. Mohammed Abdul Hamid is not available, so we will move on to Dr. Serena Vass' second presentation, acute combined ACL and MCL injuries.
Thank you once again, sir. So on the same theme, we'll continue with this acute ACL and MCL injuries. Good morning, everybody, again. ACL and MCL are the commonest combination of multi-ligament knee injuries, and they usually fail under tension. Acute injuries are less than 3 weeks old, and components of MCL are superficial MCL, posterior oblique ligament, we have seen in the previous talk, deep MCL, and there's some new light thrown on the anteromedial retinaculum, which is functionally similar and formed by the longitudinal fibers just anterior to the MCL. MCL injuries can occur up to 45% of the cases. Superficial MCL is the primary restraint to valgus and to external rotation along with deep MCL. Anterior fibers are important for rotatory instability. And posterior oblique ligament is tight in extension and slack in flexion and resists internal rotation. It has no role in anteromedial rotatory instability. Deep MCL is a major restraint to external rotation in low flexion, while superficial MCL is more important in higher flexion. Injury to the anteromedial retinaculum is 4 times more with ACL and MCL because the direction is anterior. It's the most important restraint to external rotation in extension and also from 0 to 90 degrees of flexion. From recent evidence, this appears to be more important in these injuries. Clinical examination includes tenderness, signs of ACL laxity, and for MCL, valgus stress tests at 0 and 30 degrees, and tests for rotational instability include anterior drawer with foot internal and externally rotated. Laxity is usually more in external rotation. MRI points to the site of injury. So injury can occur proximally or distally. On the left, you have the proximal injury. You can see the Contrecoeur type of injury to the bone occurring on the left side. And on the right side, you see the distal injury with the meniscus lifted up. Diagnosis is by imaging and radiographs. This shows medial drive-through sign with the meniscus sitting down, and the second part shows the meniscus lifting up. So one is a proximal injury, the other one is a distal injury. So when it gets injured distally, the meniscus is lifted up. Proximally, the meniscus is down. In both, there is a medial drive-through sign. Management would depend on various factors, and this include tear location, tissue quality, the tear grade, and this would reflect on the grade of laxity, and options of management are ligament repair, repair with augmentation, and reconstruction. We have published multi-ligament knee injury issues in Indian Journal of Orthopedics recently, and those would be good issues to go through. MCL can be injured superficial, superficial MCL, posterior oblique ligament, or deep MCL. It can also lead to secondary injuries. And there are some special types of injuries, and these are distal superficial MCL, incarceration of distal MCL in the joint, and proximal deep MCL. And distal superficial MCL, which is also called Stener type, like the injury in the thumb. After ligament rupture, the hamstrings interpose to prevent the healing of the ligament, and so these should be operated early. Incarceration is rare. The torn ligament can buckle into the joint and needs to be restored. And another injury is the proximal deep MCL, which is usually diagnosed in a more chronic setting. Management would depend on where the tear is, the grade of laxity, and we have seen the options of management in the previous slides. Conservative for both ACL and MCL is offered in incomplete injuries. Other option is ACL reconstruction where indicated, and conservative MCL. Early repair is offered for avulsion fractures, proximal avulsions, deep MCL, proximal avulsions, and grade 2 to 3, and distal avulsions. This is a proximal injury. So there is a medial drive-through sign. Proximal injuries form 70% of the MCL injuries, and you can see the meniscus sitting down. You can see the contusion of the MCL and the tear. Tear is repaired and sutures tied through transfemoral tunnel to a button laterally. The other option is to use an anchor. You can use an anchor to tie the proximal avulsion of the MCL. So the sutures are placed onto the MCL. And this shows the postoperative X-rays and assessment for the laxity preoperatively and after proximal repair. As I said, I use suspensory fixation for ACL also, both sides. And you can see MCL laxity is restored after the repair. And you can see the tunnel track parallel here. Repair with augmentation is indicated in grade 2 to 3 injuries with good repairable tissue, and options can be synthetic or biological. Arthropibrosis is a concern in these cases. Indications for reconstruction include distal mid-substance and grade 2 to 3 injuries. A recent high-quality study found reconstructions have less arthropibrosis, less failure, or failure of the MCL reconstruction or ACL reconstruction compared to repair of the MCL. And there are different techniques for reconstruction of the MCL that have been described in the literature. Fully suspensory fixation has also been described for multi-ligament knee injuries. I prefer to do these, and if required, I use interference screws, especially in high-grade cases. Moving on to reconstruction, this is a distal lesion. You can see the meniscus lifts off, and you can see the MCL under the meniscus. And this is the preoperative examination. I have used a peroneus longus graft for this case for reconstructing the MCL. And these are the lines drawn parallel to the tunnel tracks. Left is the femoral tunnel, and the right is the tibial posterior oblique tunnel and superficial MCL tunnel. Another example, this one ACL, superficial MCL and posterior oblique ligament. And minimally invasive reconstruction is possible with these also, like we have seen previously. And this is follow-up at 3 months. The patient has recovered well and is fully active. There are no tunnel convergence issues with ACL and MCL. Look out for secondary injuries like the meniscal tears, contusions, and lateral femoral fractures, femoral or tibial fractures. Root tears can occur, contusions can occur with valgus forces. With rotational forces, root tears can occur, and radial tears also can occur and include bucket handle tears. Medial meniscus tears, floating medial meniscus is usually seen with a KD3M type of injury. It's a rare lesion, and impaction injuries you should look out for. They could cause more instability, lateral femoral condylar notch sign, and lateral tibial plateau fracture. These are secondary injuries. The primary issue with contemporary techniques is the lack of external rotation control. So newer techniques are reported, and these are triple standard reconstructions or short isometric construct reconstructions, and superficial MCL and anterior retinaculum repair, but these are under experimental stages. Biomechanical testing is promising. It showed good rotational control with the newer reconstructions. Rehab after surgery includes locked knee brace 1 week, full weight bearing at 6 weeks, and at 6 months return to sport. The principles of surgery are do ACL femoral fixation first, then MCL, then tibial side of ACL. Early ACL reconstruction improves outcomes of MCL. Semi-tendinosus harvesting is not contraindicated, but watch out for avulsion of contused tendons. To summarize, MCL reconstruction has superior results to repair, identify special lesions that require surgery, and surgery offers good results for right indications. Newer constructs show promise, but further studies are required. Thank you very much.
Dr. Silvas, you come here. Thank you very much for this presentation. Now I'm going to present ACL reconstruction in the skeletal immature. Please, sir. The incidence of ACL injuries in the skeletal immature population has risen in recent years. While the exact cause is unknown, but it's likely multifactorial, including increased sports participation. Every parent wants his kid to become the next Mo Salah. Earlier single sport specialization, year-round play, increased injury recognition, this is on our part as doctors, and increased utilization of MRI. Historically, it was usually treated non-operatively by activity modification and bracing, and surgery delayed until the patient reaches skeletal maturity. Delays in surgical reconstruction may increase the likelihood of recurrent instability with chondral and meniscal pathologies, early onset osteoarthritis, decreased functional outcome measures. For this reason, surgeons have become more proactive about early surgical stabilization. So there are age and growth considerations. Near skeletal maturity, we can use traditional transphaseal adult techniques because the remaining growth is negligible. However, these same procedures risk iatrogenic damage to growth plates and resultant growth disturbance in younger patients with open physis. And as we know, most of the growth of the lower limb comes from around the knee. The distal femoral and proximal tibial physis contribute to 37 and 25% of overall limb length, respectively. Skeletal maturity is reached approximately at the age of 14 in girls and 16 in boys. However, the amount of growth around the knee that remains after 12 to 13 degrees is negligible. After 12 to 13 years in girls and 14 years in boys is negligible. So the operative intervention in this age group includes physeal sparing reconstruction, partial transphyseal reconstruction, and transphyseal reconstruction. There is currently a considerable debate regarding which of these approaches is optimal. Indications for pediatric ACL reconstruction. Number one, if the child has associated injuries that require surgery, like a bucket handle meniscus tear, or repairable meniscal lesion, or osteochondral defect. So this requires surgery and you are going to operate anyway, so why not perform the ACL reconstruction simultaneously? Number two, if the child has recurrent symptomatic knee giving way after completing high quality rehabilitation, and I would like here to stress on the word high quality. So the child has completed high quality rehabilitation and still has recurrent symptomatic knee laxity. Number three, if the child experiences unacceptable participation restrictions. Some children are high-level athletes and they are not accepting modification of their activity level and they would like to continue to practice their sport, and this is an indication in itself. So does conservative management still have a role? While many studies favor early reconstruction, other studies suggest that a non-operative approach can still yield good outcomes. This is a study that was done in Oslo. Patients under the age of 12 years recruited to a non-operative pathway after being diagnosed with complete ACL tear. These patients were enrolled in a supervised rehabilitation program and were allowed to return to unrestricted activities with a custom brace as long as they passed a functional test battery. At a minimum of 12-year follow-up, 78% of the children had not required an ACL reconstruction and 91% remained active in pivoting sports. However, 38% of patients decreased their sports activity level and 17% developed a new meniscus tear. Non-surgical treatment is viable and safe for skeletal immature patients who do not have associated injuries or major instability program, and as we stressed before, high quality rehabilitation alone may stabilize the knee dynamically without compromising the physis. Non-surgical treatment can be used as a permanent treatment for those who do not develop functional instability or as a short-term option to delay ACL reconstruction until the child has reached or near skeletal maturity. Choice of surgical technique depends on the age. In prepubescent patients with open physes with a great deal of anticipated growth, physeal sparing techniques are considered the most appropriate. To quantify the patient's age, we use a multifaceted approach, including whether the child has had the adolescent growth spurt, Turner staging, relative heights of the parents of the child, and of course the atlas of X-ray, which is now available on smartphones. The general principles of the surgical techniques are to use a well-positioned, soft tissue autograft of adequate size. This is number one. Number two, with adequate fixation to allow functional rehabilitation. Number three, minimize physeal damage to avoid growth disturbance. Number four, bone plugs and fixation devices should not cross the physis. The physeal sparing techniques avoid disruption of the physis to decrease risk of growth abnormalities and decrease risk of leg length discrepancies and angular deformities. However, they are not without their disadvantages. The all-physeal technique. The all-physeal technique involves the lateral femoral and oblique tibial tunnels, creating an acute angle that the graft must traverse. As we see, in the femur, we make it more or less horizontal. In the tibia, we above the physis and make an oblique tunnel. Ultimately, this may lead to wear and unnecessary stress on the graft, increasing the risk of re-rupture. The extraphyseal has been adopted to avoid this problem, and we put the graft in an over-the-top femoral position, like the modified Macintosh technique using the iliotibial bend. While this technique avoids the graft being subjected to acute angle, it is non-anatomic and may not fully restore normal knee kinematics. It's a combined extra-articular and intra-articular reconstruction where we may use an oblique tibial tunnel, or we may use even passing the graft under the intermeniscal ligament and then over the top position. This is the iliotibial bend, of course, with preserving its attachment here. It is primarily indicated in Turner 1 or 2. The transphyseal approach involves drilling across the femoral and tibial physis and placing a soft tissue graft across the physis to help prevent bony bar formation. And previous studies have shown that drilling greater than 7% of the cross-sectional area of the distal femoral or proximal tibial physis may predispose to bony bar formation and premature physeal closure. Therefore, we strive to minimize the damage done to the physis by the tunnel that we drill. Ensure that the diameter of the bone tunnel is as small as possible, less than 9 millimeters, and accommodate a properly sized graft. Similarly, to minimize physeal damage, orient the tunnel as vertically and as centrally as possible, and we will show just in a minute a drawing. And this while maintaining the anatomical position of the graft. On the femoral side, the surgeon may take care to avoid the perichondral ring. Drilling through the anteromedial portal may result in a tunnel that has an elliptical trajectory, so consider a slightly vertical tunnel. Like this, you see, if we drill, this is the all epiphyseal. If we drill through the anteromedial portal, it becomes an oblique tunnel like this with damage to a large area of the physis. So we resort to more vertical tunnels like we used to do before in the tibial techniques many years ago. So this shows the least damage to the physis. To minimize the iatrogenic damage to the physis, many surgeons use a more vertical tunnel placement and reaming in transphyseal fashion. A recent study showed that femoral tunnels created with an independent drilling technique disrupt a larger area of the femoral physis. The theoretical advantage of transphyseal approaches are that they may allow for more anatomic reconstruction and intraosseous tunnels that enable better graft incorporation. Partial physeal sparing techniques have been developed in the hope of maintaining aspect of anatomical reconstruction while minimizing the risk of growth disturbance. Partial transphyseal reconstruction involves drilling across either the femoral or tibial physis and using a physeal sparing for the other side. So we use a transphyseal on one side and we use a physeal sparing on the other side. Generally, this involves drilling through centrally through the tibial physis, but the femoral tunnel remains physeal sparing, as the femoral physis accounts for the larger proportion of limb growth. Avoiding disrupting its physis is thought to minimize significant growth disturbance. So here, as we see, we are drilling a transphyseal tibial tunnel and then over the top position, and now we avoided drilling through the distal femoral physis. Historically, growth arrest due to disruption of the physis has been the main concern after ACL reconstruction. However, in a systematic review by Collins et al., physeal sparing techniques accounted for 25% of angular deformities and 47% of limb length discrepancy cases. This is unexpected, of course, because it has long been thought that sparing the physis decreases the risk of growth abnormalities. Furthermore, Collins discovered that limb overgrowth accounted for 60% of cases involving limb length discrepancy. Also, there is a problem with graft tension, as too much graft tension may lead to physeal compression and damage. Furthermore, changes in the tunnel position with growth may take place in skeletally immature patients, and this may affect the tension of the graft. Today, there are no randomized controlled trials or even prospective comparative studies comparing outcomes of complications between different surgical techniques. However, Pierce et al. Performed a systematic review which included the raw data from 27 reports. To compare transphyseal and physeal sparing techniques, they have found that those who underwent physeal sparing techniques were significantly younger than those who underwent transphyseal, and the incidence of limb length and angular deformities was not different between the two cohorts. Currently, the most comprehensive review is the one performed by Collins et al. In this review, 39 patients were identified from 20 different studies. Most common growth disturbance is leg length discrepancy, with overgrowth being more observed when an all-physeal technique was employed compared to the relative shortening of the operative limb in transphyseal techniques. Meaning that if we utilize the all-physeal technique, this may lead to overgrowth, and this in itself would create leg length abnormalities or angular deformities. Post-operative considerations, pain control is very important, and post-operative rehabilitation also plays an important role in safely returning those young athletes back to sport. Several studies revealed that many adolescent patients continue to have significant strength and functional deficit after 1 year. This is consistent with the finding that a large percentage of the patients were unable to return to their prior level of sport. So this is an algorithm. If we have a complete ACL tear in skeletally immature patient, in prepubescent Tanner stage 1 or 2, we may utilize rehabilitation and limitation of activity and functional brace. Otherwise, we may do a physeal sparing combined intra and extra-articular reconstruction with iliotibial band. In adolescents with some growth remaining, Tanner stage 2 or 3, transphyseal reconstruction may be done. In older adolescents, adult-like ACL reconstruction can be done. So the take-home message is that we have increased incidence of ACL injury in skeletal immature. We may use a high-quality rehabilitation program as a form of treatment, either temporarily or permanently. Recurrent instability or lesions may necessitate operation. Physeal sparing, transphyseal and partial transphyseal techniques, vertical tunnels, transtibial, and the growth disturbance may occur even with all physeal techniques. Thank you very much. So we may have some time for questions, maybe a couple of minutes, so may take 2 or 3 questions.
Thank you for this valuable presentation. بروفيسور عبد السلام عيد. زي ما حضرتك شرحت طبعا في السكيت الماتيور بيشنت. Do you prefer interference screw or suspensory fixation in all type of immature injury? I think interference screw will act as epiphysiodesis in association with physeal injury leading to more complication. What's your opinion?
Definitely. تعال دكتور رحمن. Definitely I agree, and as I mentioned, no bone plug or no fixation device at all should cross the physis, because this will lead to physeal closure. We all strive to avoid physeal closure, and we don't put a screw across the physis. It will definitely make a problem with growth, and as I have shown in the presentation, we try to use
Suspensory
fixation methods, yes, and sutures and spiked washers and all stuff that you can put from the outside. But remember, the perichondral ring of the distal femur, you should also avoid that, because if you injure that, this may also lead to a bar formation.
This is from the femoral side, يعني it much easier, but from the tibial side. You did او يعني انت حضرتك بتعمل ترانس اوسا سوتشر ولا بتعمل برضه سسبنسري فيكسيشن بالسوتشر باتون ولا بتستخدم ستيبل، خصوصا لو انا دخلت من الايه من الفايسز من الدايفيزيال. يعني لو انت يعني انا مش هثبت دلوقتي، مش هثبت في الفيسيال رينج، احنا متفقين على كده، لكن فروم ذا تيبيال سايد وات از يور بريفيرد ميثود اوف فيكسيشن؟
لو حضرتك هتعمل transphyseal, in which case you pass the graft through the physis. If you use the iliotibial band, you may leave the iliotibial band in its original attachment, and then you use sutures or spiked washer or something that does not pass any fixation method across the physis.
Okay, thank you very much.
Other questions? تفضل.
Thank you all for your very nice presentation. My first question for multi-ligament knee injury. Regarding the MCL and the ACL, what type of graft you will use for the MCL and for the ACL?
As I've mentioned, my go-to technique for ACL currently is suspensory fixation on both sides. So because the advantage in multi-ligament knee injury is that if I take just a single semitendinosus graft, I can quadruple it, and in most of the cases the diameter is minimum of 9 millimeters in this. So rest of the ligaments, the rest of the tendons I can use for the other ligaments. So I find for MCL the peroneus longus is a good choice. But for ACL, the peroneus longus tends to be very thick if you quadruple it. So for ACL, I prefer semitendinosus, quadrupling it, and if required, you can use a gracilis if you want to increase the diameter. And for MCL, you can either use peroneus longus or the other side tendons. But I think gracilis is a little too thin for MCL.
I think they usually use peroneus longus for ACL, and for the MCL they try to keep the semity and gracilis and use the modified technique to restore the anterior and posterior bundle of MCL.
Yeah, there are various options. You can, different techniques are available, but as I've mentioned, harvesting semitendinosus and gracilis is not a contraindication in MCL injuries.
Yes, thank you. And for the internal risk for ACL, you mentioned the knee recurvatum, the recurvatum knee, and it is a very big problem for the ACL, how to protect the ACL harvesting and the graft. So if the MRI said that the FCL is intact and the dial test is positive, and there is a knee recurvatum, and the ACL is torn. And this is a complicated scenario. Will you go for the posterior medial corner advancement?
يعني you are talking about in
Near curvatum,
near curvatum and
And-
only ACL injury.
ACL, and the dial test positive.
Okay.
And the FCL is intact, the fibular collateral ligament.
A primary patient with near curvatum, it's better not to take hamstring graft from the start. Okay, it's better to take Brunnius or bone tendon bone grafting, because it's evident that harvesting hamstring tendon will increase the near curvatum. Okay. Secondary, as we mentioned, as positive dial test is not indicated for posterolateral corner injury or posteromedial corner injury. We need another test like valgus stress or varus stress test to indicate the injury. If there is intact by this test, BOL advancement or posteromedial corner advancement, we can correct postgenio recurvatum and external rotation, because we advance the flap distally and anteriorly. Okay. We ask the assistant to make maximum internal rotation. Okay. We harvesting the flap posterior to the superficial MCL and dissecting down to the posterior capsule. Everything is safe here, no problem. And we advance the flap anteriorly, so it's act as like a bridle or chakrine, prevent excessive external rotation. Okay, and then we advance the flap distally and anteriorly to prevent genio recurvatum, because we make posterior capsular shifting. Another technique can make arthroscopic capsular shrinkage by fibrosis. You can enter by your scope and apply diathermy shrinkage for the posterior capsule to decrease the recurvatum, or even make internal capsular plication by means of capsulomeniscal attachment, like we do in the hip. There's a lot of technique described for this recurvatum, but you must give a great attention to if the patient have increased tibial slope more than 15 degree, slope reducing osteotomy must be done, and only soft tissue procedure will not be efficient. But if the patient have physiological genio recurvatum, even with a small increase in tibial slope, 5 degree, you must do another procedure to make this knee more constrained, not all knee. The patient with internal knee laxity, genio recurvatum, excessive external rotation, or excessive anterior translation evident by pivot shift degree 3 or Lachman or anterior door test 10 millimeter more than the other side.
Did you think that muscle weakness?
And I would be very afraid to use the radio frequency in the posterior capsule. يعني I would not do it myself. You may have the courage, but I would be afraid to put the radio frequency on the popliteal vessel.
See, as we have heard from his talk, external rotation, ACL injury and external rotation, there are multiple things that can happen actually. There can be laxity, capsular laxity and MCL laxity along with this injury. So as we have seen, if there is laxity of MCL, there can be rotational as well as valgus component involved in it. For the rotational component, there are new techniques that are coming up. We don't have good evidence for that yet. But for valgus component, we have seen a lot of techniques that have been described for MCL reconstruction. But for all these techniques that have been published, the problem is rotational control. And for that rotational control, what the new techniques like the short isometric construct or the anterior retinaculum, using the anterior retinaculum, they tend to give a better rotational control for the combined ACL MCL injuries.
Thank you.
Yes, I agree with you, as anterolateral ligament reconstruction give a better control, but it need a second operation, second surgery, synthetic material and another graft.
Yes.
Okay.
So thank you very much. We now conclude this session, and we may go to the coffee
Thank you
break.
very much.
Thank you.